Let me know when you want to start.
Oh, we started.
Oh,
No, sorry. It's my fault.
we're live. So it is 12. So we could delve right in. Our film discussion today focuses on Groundhog Day. So where would the group like to start?
Should we just like,
Anywhere.
oh, okay.
So scene, character, other.
So, actually, it was interesting. I watched this movie like in a psych class as well in college, and so obviously, like a lot of the discussion was around the main character and how he's this cynical person at the beginning of the movie, and he's kind of resistant to accepting his reality, which is that his day, is repeating itself over and over again, and kind of like once he lets go of that that qualm that he has, he's able to progress and like get out of that that state. And so I think some of the things that we talked about were kind of like how he portrays certain like pathological defense mechanisms. Like he has distortion, is an altered perception of the reality. He's in denial. He's like not accepting his reality, and then he has like projection throughout the movie.
So let's talk about denial and projection. So what can the group tell me about denial as a defense mechanism?
Like maybe you're refusing to believe a reality, you have a bad outcome and you just internally you don't want to accept it, you don't want to face the consequences, like reactions of accepting it.
Mm-hmm. For board purposes, how might this present on a psych shelf?
Like someone not accepting their cancer.
That's a very common presentation. Right? And if you could, pardon project in terms of what that question or that vignette might address, how do you think you might construct such a question about cancer? I mean, clearly, with denial may be one of the single best answer, A, B, C, or D, right? That's fairly straightforward. But there's probably another quality to this question that is very commonly asked, which is what? It's despite the original classification, that's George Valiant, denial can actually be adapted, right? Especially given your example. So when an individual first hears of a catastrophic diagnosis, the idea that denial is maladaptive, immature, etc., and therefore itself should become the focus of clinical attention is erroneous, right? So even quote unquote denial being immature or even narcissistic, original classification really doesn't apply in 2024. Who might have been the individual, the theorist, to begin that part of the discussion? Yeah, in terms of adopting it into her theory and allowing us to really move beyond that. Where does this come up in terms of psychological theory? With bargaining. Yeah, right. And one of the first let's establish Kubler-Ross's theory. What are the 5 stages of grief?
Denial,
Anger, bargaining, depression.
Who knows? Great job there. Exactly right. Now, one of the things I want you to know, and this is less I think, a board related issue, more, I think, in terms of a clinical term, and that is, let's not forget what Kubler-Ross says later in her career, going back and revising her original theory, and that is, while she actually looked at cancer patients, I'm really sticking to your example, you really did nail an example. She did expand these 5 stages to go beyond death and dying. And our main character at Groundhog Day couldn't be employing this because he's stagnant in his career, right? And therefore, these stages are also applicable with regard to his moving beyond pertaining to his career, right? So not a cancer diagnosis, but a stagnant career. With that, before we leave this particular topic, let's overlay Kubler-Ross's 5-stage with someone that we actually alluded to of all things this morning, Erickson's 8-stage. Right. So where is our main character? By the way, what's his proper name?
No.
Is it spelled? Okay. All right. So totally blanking on that. Where is Phil with regard to not necessarily Kubler-Ross, but Erickson, and why? Or no, I think chronologically. Yeah. Yeah, so he stagnated, midlife crisis, he stagnated in his career. And it's within that psychosocial stage of development that we actually see the Ross stages play out, right? Starting with denial.
And one thing that kind of added to the Kubler-Ross paradigm too, is this idea of like making meanings, which I think is kind of, I mean, like kind of what he ends up doing towards the end of the film, right? Like finding meaning in the situation.
Yeah. Any other thoughts about Phil pertaining to his denial? Where did we see projection? I thought I heard projection.
I just think I was just saying like in general, I think that I think he's happy with like just unhappy with his life, but then he take that off in like relationships or like throughout the, like just on a situation.
I think that's fair.
Mhm.
Yeah. Any other observations on that?
The one thing I noticed watching this film the second time is that he actually had like a slight head injury before all this starts. The shovel gets hit in the head, and it's like a pretty big shovel, which of course made me think like, is that maybe what's leading to this idea or sense that like life is repeating together?
Did you completely nerd out, pause, and see exactly where in the movie timestamp?
Yeah, before it happened. So I was like, wait, what? And I went back a little bit. But then he does go see a neurologist like the first day that it repeats and they don't find anything. So that kind of left me like unsure if that was what was causing this. So
But I mean, to your point, you didn't see a psychiatrist.
he did see a psychiatrist after, and the psychiatrist was like, I don't know what to do with you.
Wonderful portrayal as usual. So in our differential diagnosis, okay, let's take a step back in terms of reframing this, because this is probably going to be worthwhile. Not necessarily in our analysis of Groundhog Day, which there will be, but in addition to your evaluation of any patient you see in the next 4 weeks of your life, right? So let's say you see a patient, we'll just name him Bill, that provides you information over the course of a 60-minute psychiatric evaluation. So this is a routine psych eval. I think step one is to make a commitment. So in formulating your thoughts, and this may not necessarily take place following your evaluation, preparing for your presentation, but within minutes of meeting a person in the clinical setting, you should really make a commitment, have an idea of whether you are interacting with A, mood anxiety cluster, or B, psychotic dissociative cluster, right? Now, the way to actually frame this, the way to actually approach this clinical question is if you could bring in 99 undergraduates from Rutgers and you polled them A or B, what would the majority say? And by framing it in that way, it prevents this group from overthinking, right? Let's keep it simple. A or B, and our patient named Phil. Doc, the reason for my visit today, AKA my chief complaint, is that I'm literally reliving the same day over and over again. I'm telling you, I jumped in front of a bus and I woke up this morning alive and well for I haven't counted, but there are blogs to suggest that it's literally over the 100th time. A, mood, anxiety, or is that B, psychotic dissociative?
Okay.
Now you're thinking.
Yeah.
What are the majority of 99 undergraduates without your level of education? It's B, right? If B step two, we're going to arbitrarily choose one illness from which to work. If B, that illness should always be schizophrenia. Like, it's arbitrary, but it does work, right? Step 3, demonstrate your knowledge of the DSM. Tell me right now what the inclusion criteria, and there are 5, are to define schizophrenia. One,
Delusions.
2,
Disorganized. Yeah, I was gonna say. Disorganized.
3, 4,
Catatonic behavior.
disorganized or grossly catatonic behavior. 5. Good. All right. Now, there are 4 of those that are positive symptoms. 1, encapsulated by negative symptoms, right? Let's just talk a little bit of neurobiology. So a little flashback to your M2. For the positive symptoms of schizophrenia / psychosis, what neurotransmitter? Too much or too little? Where? Right, yeah. D2 receptors in the limbic system. Yep. Negative symptoms. Neurotransmitter. Too much or too little? Too little. Where? Okay, perfect. All right, so that comes up on itself. All right. We need 2 criteria to meet the diagnosis of schizophrenia up to this point. Does Bill demonstrate at least 2 of the A criteria for schizophrenia? Why or why not? We rule in for delusion.
Yeah.
Here's an absence of negative symptomology. Is he a anhedonia? Let's count it. For teaching purposes, let's count. Because you know what the burn is if we're wrong, you just get taught more material. So let's say he does, for argument of this didactic. Next step would be step 4, is to appreciate that schizophrenia is a diagnosis of exclusion. So now you're going to tell me the 5 conditions that you have to consider, investigate, and rule out in order to continue to rule in schizophrenia.
Delusional disorder.
Delusional disorder is actually not one of them. No, looking at that.
Schizoaffective.
1, 2. So that's mood disorder. 2. That due to an underlying medical condition. 3. I'll give it to you.
Schizotypal person.
No. Substance use is 4. So substance-induced psychotic disorder. 4. One more. Autism spectrum disorder. ASD. Okay. Those are your 5. All right. And the reason why I wanted to go through that didactic, and we'll apply it to multiple films, is to kind of show our work with regard to where we went, saying that there might be evidence of head injury and traumatic brain injury that's resulting in everything we're seeing. Right. So I think you're absolutely right. I think it was unintended, kind of a cool thing to pick up on, and begin to kind of formulate that Groundhog's Day is a fictional case of psychosis due to head injury. And if you really want to formulate, if you wanted to present this during your case formulation, those 4 steps that we just reviewed are exactly how you would lay that. Right. And only when you provided evidence that the symptoms had their onset prior to the trauma could you move on to the other 4 conditions that you have to rule out. And then if you were able to, you go on from there, there's like a step or 2 left, right? Which again, we'll apply when we talk about our next step. That's the case formulation. Anything else? By the way, any evidence of substance use in this movie? There's a scene where he is.
Sorry.
There's a scene where he's been. Is that what I heard?
Yeah, on board. It's remembering.
Yeah. And again, if you get that information, you would not be able to then definitively rule out a substance-induced psychotic disorder. Okay, now, whether or not the movie is really about a substance-induced psychotic disorder is irrelevant. I always want you to frame this in terms of what it would be like receiving this information, perhaps even from a collateral source during a patient interview. In that case, you would keep a substance use disorder as well as a substance-induced psychotic disorder in your differential. But if alcohol can induce psychosis, because not every substance can induce every mental disorder, right? Can it? Yeah, the answer is yes. Yep, and that's the next question. So how? And there's three answers. Well, here's withdrawal.
Withdrawal.
That's the other. Yep. So it could be an indirect way by actually being directly toxic to thymus. Lowering thiamine B1 stores, resulting in a syndrome, in this case called Wernicke's-Korsakoff syndrome. Yep. And there's one more one, which is, I think, the most intuitive, which is why you guys are not you're missing it. Yeah, that's it. Again, the higher the proof and the larger the quantity, right? So think of it a cumulative dose, right? Alcohol by volume of proof multiplied by both amount and frequency will get you perhaps alcohol, in this case, alcohol-induced psychotic disorder, intoxication phase. So those are the three ways. Questions at this point? Further observations on film or off film? Let's actually continue with our case formulation, because once we're not going to do this in detail, but the answer is yes, we would investigate schizoaffective, we would investigate a primary mood disorder with psychotic features, and the way to go kind of in that direction is to ask the general question: is there a mood component to Phil's symptoms? And I knew you already thought so. And I wanted to bring that up because if the answer is yes, then both the primary mood disorder with psychotic features as well as schizoaffective disorder are not only on the table, but in our differential, right? For purposes of the shell, how do you differentiate one of these from the other? Because in a slice of time, they could present looking exactly the same, right? That a patient that presents with co-occurring mood and psychotic symptoms. Two separate answers. How do you tell the difference?
I believe with the mood with psychotic features, it's you have to have 2 weeks of like mood, depressed mood, or like the mood symptoms without the psychotic episode or psychosis.
I think it's the other way.
Oh, it's the other way. Okay, for the other or
Just
it's different. No, it's different.
So here's the easiest way to do this. And again, it's fairly intuitive. It's to make a ton of sense. The patient that's sitting in front of you has both co-occurring. They must demonstrate at some point in their past psychiatric history evidence of one without the other. Right? If that patient presents with psychotic features and with absent mood symptoms, you sitting in front of you must be a primary psychotic process. And the opposite also holds true. If that very same patient or their monozygotic twin came in, exact same symptoms, exact same duration, but instead presented with evidence of mood symptoms, absent psychosis, it must be a primary mood disorder, right? So that's the easiest way to think about it. The only other thing to consider is timing, duration, and this is the reason why. A patient sitting in front of you with co-occurring mood and psychotic symptoms, whether it's the patient or collaterals, you're provided information that there does appear to be psychotic symptoms in the absence of city caps, in the absence of dig fast, in the absence of a mood component. And you ask, how long did that last when you had one without the other? And they say 45 minutes. That's not going to help you. All right. So the question really defaults in terms of not necessarily what, but how long is it relevant? How long are you, or how are you going to operationalize duration being relevant? And the answer there for the APA is 2 weeks. Right. So just think about it like that. And the opposite really holds true too. If you see mood symptoms, so you weren't wrong in your initial answer, it's just that it's published in the DSM for schizoaffective.
Okay.
Right. Here's the other clinical problem. If, let's say, someone did present, maybe his name is Phil, and they present with co-occurring mood and psychotic features. If you're going to investigate this being a primary mood disorder, where might you go in their past psychiatric history that might have the highest yield of his having psychosis without mood? So it's a primary psychotic disorder called schizoaffective. And the answer is anywhere, right? That's why you need that 2-week window. So it could be anywhere. It could be in the last 2 weeks. It could be when he was 13, well, not 26, right? On the other hand, if that monozygotic twin came in, exact same symptomology, and you were suspicious that this may actually be the opposite, a primary mood disorder with psychotic features, and you wanted the highest yield to investigate whether or not they had mood absent psychosis, where might you go in their history? And the answer is at the onset of the illness, right? Because it's intuitive that people who become depressed often start mild, can actually evolve to moderate to severe with psychosis. So that's where the 2-week window comes in, right? Questions about schizoaffective versus primary mood with psychotic features? Okay. Once you investigate these conditions, definitively rule them out so as to support the provisional diagnosis, in this case of schizophrenia, there's really one last step. And it's a bit of a thought exercise, and that is, hypothetically, if you had taken notes on this film and you could cross out everything on your notes page that is explained by those diagnoses we discussed up to this point, would there be anything left? Because if your answer is no, they're all crossed out, you're done. Right? And you should provide or perform the same task when you take notes from a patient interview. If there's anything remaining not crossed out, guess what? You have to expand your differential. And to do so, it should be in a stepwise progression. That is, if you're down choice B and you're discussing schizophrenia, the next step would be to go to other psychotic disorders that the DSM does not require you to pull out. And if you still can't find that condition, you can expand to the dissociative disorders chapter. If any of the dissociative disorders chapter do not account for those notes you have remaining, then you go everywhere else. Okay, so that's the 3-step progression to kind of end your case formulation. In this film, if you were to look at your notes and cross out everything that would be explained by schizophrenia, schizoaffective, primary mood disorder, that due to an underlying medical condition or the direct physiologic effects of a substance, would you have anything else there? There might be one thing.
I like narcissistic trait.
Might be 2 things. Let's talk about that, right? Yeah, there's elements of narcissism here. They're condescending, very arrogant. And if we found that that narcissism was both stable and pervasive, as well as being clinically significant, that it impaired his functioning, we need to investigate a possible personality disorder. So I think that's very fair. The other thing I wanted to bring up is that there was this element that falls outside of the DSM diagnosis of schizophrenia, of just feeling things were strange, things were off, with insight, right? I mean, he didn't wake up with this delusional belief, this fixed belief that this was happening. He was distressed by it. This can't be happening, which shows me that he's insightful. And that's really not consistent with what we would expect from a primary psychotic process, right? That is, at least in the beginning, he actually gained some element of reality testing. So what would you call it when an individual has this odd sense that the environment around them is unreal in some way and they're disconnected, and maintains a level of insight that, and therefore they seem to be reality based?
Disassociated.
Yeah. Yeah, this is where we maneuver over to the dissociative disorder chapter of the DSM. And that condition would be depersonalization / derealization disorder. You have to say the slash. It's just written as such. Okay. And that I think that really should be in a differential diagnosis here, whether he has either a primary or co-occurring dissociative disorder. And I think the single best diagnosis to actually describe or explain what he would describe as the sense of his environment being unreal would be depersonalization, derealization disorder. That's a consideration. Okay. Any other observations? How about any characters in this movie other than Phil? Take your brain. Any other thoughts from your previous class, having previously watched and studied this film?
From what I can remember, we mostly focused on Phil, and then also like kind of the narcissistic side of the personality side of his character. So I don't recall like our discussion about the other characters.
So let's talk a little bit about personality disorders. Because again, I think it's a fair assessment here. There is evidence of this arrogance, this haughtiness prior to any of this, right? Prior to the onset of any symptoms that might be considered psychotic or even dissociative. So it seems to be a pre-existing condition. And we'll assume, but let's actually let me backtrack. I believe at the last count there were six criteria that must be applied to every personality disorder in order to rule in or call it a personality disorder. Right? We may have mentioned some already. What are the six criteria? Because as we discussed the individual personality disorders, I don't want to have to repeat all six every time. All right, so let's get them out of the way because they apply to all of the above. What are those six elements defined through a personality disorder?
Some sort of like functional impairment that affects their social ability, affects occupational ability.
Definitely. These disorders are usually taught on the periphery. It's almost as if psychiatrists and clinical educators are a little ashamed of these being real diagnoses, quote unquote. And we tend to kind of give the message that, unlike major depressive disorder, schizophrenia, that these conditions do not result in clinical impairment. And that is absolutely false, right? So they can be as debilitating as severe and chronic mental disorders, no doubt about it, right? So that's definitely one of them.
It's stable, pervasive.
They're stable and you said
Okay,
pervasive. What does that mean?
you know, like you see it consistently in all aspects of the person's life.
Right.
One thing.
Right. So if you're attending with a narcissist, and then you met them outside of 9 to 5, Monday through Friday, and they appear to you to be a quote unquote completely different person, that's not pervasive. Okay? So it must cross social settings, and stability is also true. I mean, you are who you are, for better or for worse. I mean, theorized, late adolescence, early adulthood. And that's true for personality disorder as well. We don't outgrow our personalities, and therefore we don't outgrow personality disorders. Now, having said that, when we talk about the individual states, there are 3 or 4 that tend to improve over age, and that's in the empirical evidence. So we'll get to those stuff, but for all intents and purposes, they are stable, and that's by definition. What else?
Is another criteria that they don't need any other like mental health
Yeah,
disorder.
exactly right. We would always reserve clinical judgment of a personality disorder or for a personality disorder in the setting of active mental illness, right? Because again, when you're sick, personality variables tend to be accentuated, and we don't want that misdiagnosis. So we always have to investigate the primary mental disorder. Or I think there's 2 more.
So there have to be some sort of functional impairment.
Yep.
But then it has to develop like before a certain point in life, like when you're young, or to be considered a personality.
We're gonna roll that up into disability.
Like perception, it changes. Like people with personality disorder, do they have to have like an altered perception or like reality?
Yeah.
Is it both thoughts and behavior? Does it require both those two elements?
It definitely could and often does, and those are built out to the individual or specific
Right.
criteria for each, yeah. The other two are missing here, again, the intuitives, you guys are just beyond that already. The personality change, the personality deficit cannot be due to the direct effects of a substance, nor can it be due to the direct effects of an underlying medical condition, right? So give me an example of personality change due to an underlying medical condition.
Aggression with Alzheimer's,
Aggression with Alzheimer's, yeah.
or anything dementia.
Yeah. Any others?
Like depression with anything.
Yeah, I mean, neurocognitive disorder, yep, in general. And then a favorite on exam is Pick's disease, Pick's dementia. Right, when the postmortem biopsy shows inclusion bodies, comes up on exams all the time, right, due to an underlying underlying medical condition. I don't think you're going to get this in an exam because it's way too obvious, but usually in psychology 101, maybe even N1 classes, the case of Phineas Gage. Traumatic brain injury is often cited as well. And there's and you'll see brain tumor come up on exams too. And if there is going to be an MRI on a psych shelf, it might be that. Right. Infamous fictional character, antisocial personality, and secondary to glioblastoma. Yeah. Carrying that diagnosis is a bit controversial for this particular fan base because he also had his wife incur significant injury, losing her child during a physical altercation and connected on maintenance. So there's definitely a psychosocial component to the onset of a psychopathy as well.
Definitely.
One of the more popular franchises in horror. No, huh? Jigsaw or John Kramer from Saw. No one, huh? Go home. Got one for really, that's it, really, that one. Ouch. All right. Trust me, secondary to glioblastoma. All right. Now that we know the 6 criteria that apply to all, let's talk about the cluster B personalities, and let's start with narcissistic personality disorder. When you study for yourself, I think it's perfectly okay to outline these conditions according to their cluster, right? A, B, and C. However, after reviewing per cluster, what I would also definitely suggest you try is reorganizing these conditions into 2 columns. Those that actually adhere to a cardinal trait and those that do not. And the great news is that all but one does. In studying these then, final review, and prior to your shelf, know that cardinal trait, reread those diagnostic criteria that you've been studying this whole time, and they will automatically default to simple examples of that cardinal trait, right? It'll just, the light will go on. What is the cardinal trait? And it's usually a 1 or 2 sentence blurb to have us remember narcissistic personality disorder. Right? The individual is arrogant, they believe they're special, and could only be understood by someone as special as they are. That's it. And then you can look at all those criteria, each one just matches up with that. So you don't have to memorize the actual DSM criteria. Okay. Do you think that Bill rules in? So I'm
Yes.
getting into a significant amount. Treatment. You're not going to be able to prescribe a day repeating itself over and over until it figures it out.
Is it CBT?
There might be some benefit to that. That's clustered with borderline personality, but by far, borderline personality is the single best answer there, right? Generally speaking, psychotherapy. The use of medications is extremely limited, and similar to all personality disorders, is really only relegated to adjunct therapy. So if there's a presenting symptom that you feel warrants independent clinical attention, the usual off-label use of a med might be something you prescribe. And by the way, in terms of practice, and I don't think this will ever come up on a shelf exam, but certainly in practice, Pearl, once that symptom improves, withdraw the medication, right? Because if you don't, in a year and 5 years, your patient's going to be on so much polypharmacy that the side effects are going to really be the focus of your attention in terms of getting them through day-to-day life. That can't happen. Interestingly, for the narcissistic personality, it is not one of the 4 that tend to improve with age, which would have been kind of cool if it was, because the way this movie presents aging, and his ultimate outcome would have been actually evidence-based. So maybe that suggests that Bill has a co-occurring condition other than narcissistic personality disorder. And maybe it's one that may improve with age. And there's 2 from cluster B that actually fit this here. So what are they?
Kind of improving it.
2 cluster B personalities that the empirical evidence demonstrates may improve with age.
Yes,
Yeah, antisocial personality. And the other one? Borderline personality. Yeah. So let's talk about these. Let's talk about antisocial first. Give me that cardinal trait. Latent disregard for and violation of others' rights. Okay. Again, clinical criteria, just merge with that. Interestingly, this particular condition requires the lowest threshold quantitatively. It's only 3. No other personality disorder requires just 3. However, to reach criteria, the individual must also demonstrate aspects of conduct disorder prior to the age of 15. And that's in play, no place else in the personality disorders chapter. Right? Is there any evidence of antisocial personality itself? It's too bad, because that would have been perfect. It really would have been. It clusters not real nice with what I think his prevailing problem is in terms of the personality disorder, and it improves with age in a way that only Groundhog Day can actually portray. So I suggest that there's a flash sideways, that if we could create this character in another film, he would absolutely have a social personality. It's the only way I can make sense of it.
I will say like some of the endings fit that his personality really well, because like he is the head honcho in this town now. Everyone does regard him as like special or like different, and he chooses to stay there. And he does get this person who, Rita, who he feels like no one can understand him. And in some ways, like I could see him coming in with children and his family because they're having issues, but really it's because he's still like autistic personality disorder. But I think in some ways it does kind of fit that what you would see for someone who had gone through this whole cycle.
Yeah, I don't disagree with you. So on the surface, superficially, it looks like he improves with age, but a little bit of a deeper dive, we do notice that he does stay there, and it's a bright fit for him, right?
He doesn't ask her, oh, what you think about it? We're staying and I'm marrying you. Like, no, he doesn't ask her, he didn't ask her opinions.
That's the point.
He's just deciding they're doing it.
The other condition I wanted to briefly touch on is borderline personality. Unfortunately, this is the one that does not have a simple cardinal feature. So we do need to dedicate some time to it. And what I would like to do in the moments we have left is kind of circle back to where our conversation first started, and that's end this discussion on some of the characteristic defense mechanisms that define borderline personality. Okay, so this is a condition again, no cardinal feature, but as you remember, three defense mechanisms that are characteristic of this condition, you have three criteria that are handed to you. So any guesses as to the characteristic or common defense that's employed by someone with borderline personality disorder? Splitting. Good. What is splitting? Yep. Right. Anybody have a problem with the definition? Right. And that usually results in over idealization and devaluation, usually of the same individual, and it could be doing at the same time. Right. So the DSM criteria is mood lability, affective instability. Yeah, it is thought to be the direct result of splitting. Right. So that is a diagnostic criteria. Two other defenses. One's a bit of a cheat. It's dissociation. Okay. Dissociation is really on a spectrum. One is starts off dissociation as a defense, which could be adaptive, right? I mean, maybe you can probably dissociate at your drive-thru. Right? It may have been 2 blocks before you realized that you weren't paying attention to every single part of it. Right? Right? Of course, that could become maladaptive. It could become the symptom that warrants independent clinical attention, perhaps associative disorder such as depersonalization, generalization disorder. And then again, of course, the most severe form yet to be discussed is a condition called TID, right? Dissociative identity disorder. But the DSM criteria for borderline personality is actually dissociation. So it is a defense mechanism. It is the criteria is the defense, or vice versa. The final defense that is somewhat characteristic of this condition is passive aggression, and that's the inward turning of a nihilistic impulse. Right? That nihilistic impulse for the individual with borderline personality is often anger. So, by the way, that is actually a diagnostic criteria. So that's 4 now. And when anger cannot be discharged appropriately towards the person that you want it to be discharged to, and your superego simply will not allow it, if the defense is passive aggression, that anger turned inward can lead to a suicide attempt or a suicidal gesture, which is itself a diagnostic. Right. So suicidal gestures, dissociation, mood lability, affective instability, and anger, 4 of the 9, I believe. DSM criteria, skipping past any cardinal feature. Do we think that our main character in Groundhog Day rules in for borderline personality? Probably not.
No.
Okay. Just to name histrionic personality, we won't get into it. There are probably other movies that better, I think, influence our discussion on this condition. So we'll reserve further discussion. But just to name the 4th and final cluster B is histrionic personality disorder. Yes, there is a cardinal feature, and it's the need, the overwhelming need to be the center of the picture. Final thoughts, final questions. Groundhog Day.
I remember like someone also made a comparison of like this like movie being like a comparison to like psychotherapy, and like him having to confront his problems until he like comes to resolution. Maybe he was like, maybe that could be like taken as like he was depressed before, kind of working through that internally, and then like finding results. Yeah.
I find that. So just to kind of go off that, and this is not for the board supports, but can we reflect back on any character that we saw that may have been the therapist? I don't think anybody was written into the script as being a physician or a psychologist. I don't remember. Or even a social worker.
You saw like one psychiatrist, right?
Yeah.
Mhm.
Because sometimes movies like that, where you have a big reveal at the end, it's a character that we weren't expecting
Yeah.
to actually be the central character after all. Who's wondering if we could find some hidden character, some political character that we may have only seen once. Actually be the very person that is in therapy with the whole time.
Mhm.
Only thing to be revealed, if not at the end during a podcast. That's an interesting thought.
Do you ever think about how long he spent in that cycle of waking up every day? Like, was it years? Like, the movie kind of implies it's a long time. Do you ever think about like self-actualization? Like, how long did it take?
The only time frame they provided was early on, they could have been 6 months, but then it kept going like for a long time after they went back.
Yeah.
Piano, like.
It could have been like 100 years.
It could have been, and there are people that have geeked out on Reddit and have counted.
Oh, really?
Oh, yeah.
Yeah.
Yeah, I withstood every temptation to do that. Again, every year I struggle with that. So I won again this year as the other results. But it's there.
Mhm.
You know, it's definitely, it might even be up on YouTube as well.
Mm.
But Reddit definitely has it. I've seen it before. All right, guys, we'll end it there. All right, I will post next week's film and next week's Seinfeld episode